We're delighted to be joined by Dr. Tim Triche, Professor of Pathology and Pediatrics at the University of Southern California, Children's Hospital, Los Angeles. Tim, thanks for joining us today.
It's my pleasure.
Tim, how difficult is it to diagnose and treat childhood cancers?
So I need to break that question into two pieces, diagnosis and then treatment, because they're fundamentally intertwined, but they represent different challenges. The problem of diagnosis is compounded by the fact that childhood cancers tend to look very embryonal or fetal, very primitive, so-called round cell tumors. And thus they tend to all look alike. And so morphology or histomorphology under a microscope, which is the basis of most cancer diagnosis, is by definition more difficult in childhood cancer. And for years it's been a diagnostic dilemma, and it's been largely solved by using additional diagnostic modalities, most recently next-gen sequencing. And that's important because all treatment, which is basically chemotherapy-based, is predicated on the right diagnosis. So if you don't have the right diagnosis, you don't get the right treatment. And surgery may play a role, but it's been long known that surgery alone doesn't cure childhood cancer. So by definition, you have to use the right selection of drugs. That's based on the diagnosis. Once, however, we've established an absolute unequivocal diagnosis, which often takes specialized diagnostics, by the way, one can then usually enter into a frontline therapy because most childhood cancer has standardized frontline therapy now.
When you're thinking about a treatment plan, what's different about the decision criteria for pediatric cancers versus adult cancers?
With all due respect to my adult oncology colleagues, I would submit that in the case of childhood cancer, our problem is trying to identify standardized chemotherapy protocols as well as novel chemotherapy protocols, because as I noted, we have to use these agents to cure childhood cancer because surgery alone doesn't. And so, whereas adult oncologists will often be dealing primarily with surgery, then perhaps also radiation therapy, and then using perhaps a limited cocktail of chemotherapeutic agents to ensure that things like micrometastases have been dealt with, it's almost the reverse problem with childhood cancer. We know that we have to use chemotherapy, and that chemotherapy has to be chosen based on the best available evidence. What's happening now is that more and more evidence is coming from next-gen sequencing that allows us to identify novel agents that we never knew before might be beneficially used in the treatment of children. And that's interesting because most of those agents were developed for adult cancer, but when that same defect occurs in childhood cancer, we're able to use these agents off-label to treat the children.
How useful has genomic data been to support advancements in diagnosis, prognosis, and treatment selection in recent years?
It has changed everything. When you think about where it all started, we were doing single one-off assays. For example, when it was recognized that poor prognosis childhood neuroblastoma was related to amplification of a gene called MYC-N, N for neuroblastoma, it quickly became obvious we needed to develop an assay for gene amplification. And once this was realized at a research level, everyone scrambled to develop an assay to measure NMYC copy number, which was fine, except that was only one of multiple features that you'd really like to know about. And so for years, we kept developing one assay and one assay and one assay, and they've been absolutely critical to allocating patients to high risk versus low risk protocols. But of course, this idea of having serial assays means that particularly with the advent of, for example, in the NMYC example, you can also have co-amplification of ALK. And ALK, by the way, could be treated with an ALK inhibitor. And if you just do the NMYC assay, you won't know about that. So having a comprehensive assay panel has really been a huge boon to both improving the diagnostic accuracy and leading to novel therapeutics beyond the frontline therapies. And that paradigm has now sort of spread throughout all of childhood cancer, and thus you need a platform that can do all of those: NMYC copy number, c-MYC expression, right on down the list of all the features that we find in childhood cancer that are unique to that disease. And so in an ideal world, for example, using next-gen sequencing platforms capable of doing things like copy number, mutations, gene fusions, and so forth, you're able to do all of those old single one-off assays in one large NGS assay.
Tim, when you're working with a care team or a tumor board, do you consider things differently when next-gen data is available versus when it's absent?
Absolutely. You know, all institutions, ours included, have had their traditional tumor boards where all the various specialties come and discuss the case. You know, the surgeons, the oncologists, and so forth, all attending to discuss the management of a case. But what we see evolving now, including our institution, are so-called molecular tumor boards, which exist specifically to discuss the findings from next-gen sequencing panels like what we call OncoKids. And it has been a huge success. It's fundamentally changing the way that we're dealing with the children with cancer at CHLA. Specifically, when we first introduced the assay as a laboratory-approved, CLIA CAP-certified assay, in the first 6 months of use, we ran 200 assays, which is almost all of our new admissions. And the important result is that over 60% of the patients had actionable defects, and that's extraordinary because no one expected this. And I can tell you that it has completely changed the attitude and the appreciation of the oncologists for the availability of that data, and it's led specifically to different treatment decisions based on those results in many cases.
Tim, thank you again for sharing your thoughts and expertise in this important topic. In our next video, we'll learn about the Oncomine Childhood Cancer Research Assay and other collaborative efforts that Dr. Triche is involved with as he works with others in the community to advance research in cancers affecting children and young adults.